was a bit easier to search down the trigger points and to compress like ICT technique, ICH technique, what we learned. So it was a bit easier for instant relief. A few days ago, I had a patient who came down, ki, doctor, something is happening to me, and maybe I'm getting a heart attack. This was what she explained, and she was panicked. So I asked her to just sit down, check her spine and her back. So it was inflamed. Then I searched down with a trigger point, compressed it, and she was relieved very instantly. She didn't return back. I called her, so she was like, "No, I am fine now." Okay.
So the other side is you will be missing patients fast as well. Patients won't come back to you. You're just treating them in one session and one thing. So but don't look for the short term issues. Whenever that patient has any pain, they'll come back to you first. That's the lesson that you have to keep in mind. So next time they will remember you with any slight. So that's how it comes. When you think that that was probably a case where you would have given probably 2 or 3 weeks of medicine and something blah blah blah, like the normal thing that we do. And sometimes it's not. So that's how it is. Great experience. I'm really happy. Anybody else who witnessed something like that would like to share their experience?
Doctor, I also experienced this, but on myself. And I used to have a very long-standing pain in my arm, and I was ignorant about it, and I was just letting it, go by every day. But then after I heard you, and we discussed the trigger points, so I tried it on myself. And I should say within one day itself, I was relieved of the pain which I was suffering for many weeks. So it was a great experience on myself. So thank you.
I think, that's the best part. You first experience it on yourself, then you will become master very quickly, because you know the onset, you know the pain, you know the difficulty that you're facing. And then when you do this technique, the effect of this technique. So, you're experiencing every aspect of it. So you will be able to convince the patient even better. So, that's why I say, try always, these things have to be done like in, like one-on-one training, or where you do it on someone and then somebody does it on you, so you experience it. But, still, I think, I think we'll have to get used to the new norm of doing everything online. And I'm sure this is a beginning, and you can definitely, start doing it on yourself or your relatives to feel that, the change. So, okay. So, any doubts as such? Is there any part where you can just, post it on chat, or if there's anything you can discuss, if you wish to discuss it before the session, if there's somebody who has any doubt, you can just ask now. Just wait for a minute or something.
I would like to know more about the reciprocal.
Okay, you're talking about the reciprocal stretch that we talked about. Reciprocal.
Yeah.
Okay. So, okay. Basically, whenever we do trigger points, or whenever we talk about the musculoskeletal system, we need to understand the muscles that are involved in that action. So we categorize it as the agonist, antagonist, and the synergist, right? So what happens is, when we do, and we talked about the isometric stretch, right? And in the reciprocal inhibition technique, what happens is that you have the trigger point on the agonist muscle, but you are doing an isometric stretch of the antagonistic muscle. And when you do that, because of the reciprocal inhibition effect, the the agonist muscle actually heals, or the trigger point in the agonist muscle heals. That's what reciprocal inhibition means. So initially, the what do you say? The stretch that we all should learn is the isometric relaxation, the isometric stretch. Then we can talk about the isometric relaxation technique. And Dr. Jasul shared passed an information that some doctor had requested to do a demo in another muscle as well, so that you can understand the technique. Instead of just the biceps. So I was showing it on the biceps because it is easier on the camera. So this doctor had requested that I do it on any other muscle so you can understand it. So what I thought is I will do that different kind of stretches. I will explain it once more in a video, and I'll post it on Facebook group, right? With another group of muscles or with another joint. So you'll be able to understand it better. Okay.
Yes, sir.
So let's today we're going to talk mainly about let's get to the the treatment aspect of it, and let's see what are the concepts that you should get, because the basic of everything is trigger point, is understanding trigger point. And once you understand trigger points and you understand how body behaves, and how brilliant our body's network is, then there is a lot of it's a new doorway for you to explore lot of different therapies. That's right. So once you're into trigger points, trust me, this is not where you stop. The next thing you will be going is more deeper, because you will be getting the feedbacks from the patients. Now, until now, it was, we were not, focusing on one point, or we were not pressing it or beyond a certain level. We were not finding anything. But now on, when you find, you're going to get feedbacks from patients, and that feedbacks is going to really surprise you, because you will hear that somebody, sometimes you're looking for the patient is on a prone position, and you are busy searching for a trigger point in the infraspinatus muscle, and suddenly when you're trying to press and to make sure it's a trigger point, and when you press, the patient will tell you, doctor, when you press, I got a pain in that area, but that pain was actually radiating to the tip of my fingers, right? And in another instance, you're going to find where people will tell you that you are, focusing on the shoulder, and then when you press on the shoulder, the patient will be like, doctor, when you press it on the shoulder, I was getting a pain in the back. Sometimes when you're pressing the calf muscle, they say that when you press it, I got that exact back pain that I was having. And you're going to find these, incredible, connections in the body. So just be open to that, because your study doesn't end here. That's what I'm trying to say. Don't think you're just going to sit with trigger points, because once you start treating people based on trigger point therapy, then it says somebody says if there is no audio. Am I audible?
Yeah, it's audible. You can continue. Okay, I can clarify that.
So we're gonna find, and this is how it makes you interesting. You're not going to stop at trigger points. We're just going to explore more about fascia. Then we're going to go into the anatomical trains, and then once you do that, then it's going to be more of corrections, joint mobilization techniques, and so on and so forth. And then slowly you're going to enter the the sacrocranial, the connection between the brain and a lot of other aspects. So this is just a beginning. So trust me, and keep practicing it, because only then you will be able to really appreciate how excellent or how magnificent or how incredible a human body is. So hands-on techniques is something that we have to do, and and this is where the importance of probably why there was something called as Sparshana Pariksha, Darshana, Sparshana, and Prashna. It was given equal importance, but in practice, we lost the Sparshana aspect, or we do it for just, like some ascites or abdominal, investigations. That's it. I don't think we do it for any other area, right? So, and once we go into trigger points, I just would like to quickly take you back to our own science, what we have been dealing about. Marma, nothing great. I wouldn't say trigger points and marma are one and the same. But if you notice, most of the trigger points that are formed in the body are closely in I would say not in contact, but the location is very near to probably a marma point, right? Uh, and not just a marma point, also an acupuncture point. Here is where everything comes together, right? So if you look at this picture, you have this. Actually, I'll just take my card. You can see Urdhvaskandha marma that is there. This is basically a comparison of marma and acupuncture points, right? What you see is GB21. Those who know, acupuncture, or those who have a little bit of acupuncture will actually see. So I'm just gonna mark few areas, right? So this one, it's like the most favorite spot in the body. This is the trigger points in the upper trapezius, right? This is the point which is called as GB21 in acupuncture. In the Vedic text, this is called the Urdhva Skandha Marma. You learn varmology, right? When you learn varmology, this is called the Kakatai Kala, right? So any literature that deals with marma or anything, this has to be there. This again, and also, okay, yeah. And this area is the Amsaphalaka marma. Here is the SI11, small intestine 11 in acupuncture. The infraspinatus trigger point is usually found here. And this, I'm sure this is very common. This area, everybody comes to you with this, right? The Prishtamarma, rhomboids, right? Most closely here. So this is how it is going to be, And once you learn about trigger points, and once you learn about all these things, then you're going to open yourself into a little bit of acupuncture. You're going to open into marma, and you're going to open into fascia, and a lot more. So this is the just a comparison on the upper back. Next, this is the marmas and trigger points, and we'll just do a small comparison. So here's the sternocleidomastoid muscle, right? We talked about it a lot of times, and you have the this is called the LI17 in large intestine. 17 is called close to it is your Sira Mantha. This is called large intestine 18, right? Close to that is called the Mantha. Here is the GB12, right? And here is the Karnamula 2, also called as Chevikutrikalam in marmology. So, there was a reason why people found importance and relevance to these points, right? So here is the connection that we get, because it is very difficult to understand marma therapy, because people we just do it. We have to do it blindly first, right? We learn the names, we just learn how it is manipulated, and then slowly we feel the technique. That's how Marma is taught. You just name of the Marma you learn, you understand how to treat it, and you know what organs it affects. But then we have to do it by heart, right? So once you start doing trigger point therapy based on muscles, we we are entering into the physical part of it first, right? The anatomical level, and then slowly you can lift yourself into the Marma or the meridians and all those concepts, right? So this is where everything begins. Again, here, right? You're the Adipati, GV20, very important Marma. Yeah. Shivarandra. Then you have this area is very important in relevant in today's world. Most of the headaches, the conditions where we talk about people having irregular baths and etc. This is, if you just press it and see, you can see how painful it is, right? And when you relieve the trigger points and when you relieve the fascia here, the patient feels a lot of difference in how they are feeling and everything. So just a comparison, the upper limb, how it is all connected. So just quickly talk about, because I wanted to actually introduce the trigger points, and we'll talk about few muscles in the cervical area and upper back. So we'll just talk about, how the extension of the movement of the shoulder joint, right? So if I can. Okay, so to increase the size of my video, I have to minimize I have to stop screen sharing, right, doctor? Hello?
Yeah. Now, yeah. It's okay now.
You can see my.
Yeah.
Okay.
Yeah, we can see you fully.
So we're just going to talk about, the shoulder joint. So, the one movement of the shoulder joint is the extension, right? So in the extension of the shoulder joint, what are the muscles involved? You have the posterior deltoid, you have the latissimus dorsi, and you have the teres major, which acts as your agonist muscle, right? And the antagonist muscle for the extension is your biceps, your pectoralis major, your anterior deltoid, and your coracobrachialis. Okay? And it's the same, these muscles that are the antagonist in extension becomes the agonist when you're doing a flexion. So you have your biceps brachii, you have the pectoralis major, you have the anterior deltoid, and you have the coracobrachialis that will act as the the agonist muscle when you're doing flexion. So flexion, extension. Why are we talking this? Because you're going to have people coming to you saying that, doctor, I'm not able to lift my hand like this, right? So what are you going to say? You're going to first look, okay, this person is having a range of motion problem, and which range is affected or which motion is affected? Flexion. So what do? We first look for any sort of stiffness or tenderness in the agonist group because he's having problem flexing, right? So sometimes what happens, there might be stiffness or there might be pain trigger points. He may not be able to contract this muscle. So the agonist the agonist group might be affected in flexion. So when we analyze, we check for biceps brachii, there's nothing. You see for pectoralis major, there's nothing. Anterior deltoid and coracobrachialis. Now all these muscles, if you feel it's okay, then what we do, we go for the antagonist muscle. That is the posterior deltoid, latissimus dorsi, teres major. Because remember, when this contract, the opposite side has to relax. Now, this is the concept that we have to keep in mind for all the joints, right? We'll talk about the abduction, right? The abduction, we had talked about it on when somebody asked about this. I think on the first, somebody asked about what is an impeachment. I'll just repeat it again. Okay, so you're talking about, this is the right shoulder joint, right? So when you're talking about the abduction, what happens is the first 0 to 15 degrees of abduction is produced by the supraspinatus muscle. Okay, so what it does is, and the middle fibers of the deltoid is responsible from 15 to 90 degrees. And past 90 degrees, the scapula needs to rotate and achieve abduction. That is carried out by trapezius and serratus anterior. Okay, so what does it say? First 0 to 15 degrees, it starts with the supraspinatus. And what it does is it slowly glides and pulls the humerus down. And from here, the middle fibers of the deltoid connect, and then it extends, right? And past 90 degrees, what happens is, once it reaches 90 degrees, beyond this, what happens? The scapula slowly moves in this direction. Okay, so what happens? The main muscle is the trapezius and the serratus anterior that actually lifts the shoulder above, but the antagonist muscle is your rhomboids that is connected here. This is what sometimes happens. People come with pain at the back, right? They're having problem. They don't have a problem here, but beyond this point, they're not able to lift it. And sometimes you can see that it could be, you're doing, because what we learn or what we understand is, this is the type of ababahuka. So the shoulder joint is affected because the range of motion beyond 90 degrees is not possible. So what we do, we do like Sthanika Abhyanga, Sthanika Kiri, etc. over here. But what is the actual problem? He has the stiffness or an issue in the rhomboids, because what is happening is his rhomboids that are connected to the medial border of the scapula, it does not relax or does not.
Doctor, can you raise your hand? Yeah. Now it's more visible.
Okay, I'm sorry, because I'm not seeing the picture. That's okay. Let's see.
And
okay.
View who is talking mode. Okay.
View who's. I think it's better now, but okay. What was the part here when I talked about the extension of it, or no? I was like this. Okay, so I'll just repeat it once more. Okay, so what we're talking about is, this is your right, your right shoulder. This is a view from the posterior. Okay, so for the abduction of the humerus, right? The initial 0 to 15 degrees, that is 0 to 15 degrees, is done with the supraspinatus muscle, is the primary mover, or the agonist muscle. 15 to 90 degrees is your deltoid, right? The deltoid takes over, right? And below 90 is your trapezius that is connected from your, the nuchal line. It lifts your hand up like this, right? And at this very particular point, what happens is, the movement till here is okay. Till here is 90 degrees. Till 90 degrees, the humerus rotates within the scapula, the glenoid. And then beyond this, what happens is your scapula also rotates like this. Only then your hand will be able to move. This is a very important, because what happens is, if your rhomboids, that is connected to the medial border is tightened, that is right at the back, if it's stiff, the possible movement the movement that a person can do is only to 90 degrees, and beyond that, his rhomboids won't be relaxing so that the scapula rotates, right? And what happens is, like I said, we will be more focused on, the Sandhigata Vata, Apavahogam, and we'll be doing a lot of changing potleys, and all that. So that is what I used to do, and that's exactly what I feel is, has changed over the past when I learned all these. Next is, so we talked about abduction. Next, we talk about the adduction, right? Okay, so when we talk about the adduction, that is, your muscle is, it's the process of bringing your arm down, produced by the contraction of the pectoralis major muscle, right? And the latissimus dorsi, if you remember, and the teres major muscle, right? It acts as the primary movers. Now, what happens sometimes when you see people, when they are in the in the droni, in the massage table, when you ask them to lift their hand up, what happens? Some people cannot touch this hand on the table because they will be having very tight pectoralis muscle. And after a few couple of massage sessions, that's when you feel this hand is more extended, right? And I have my therapist now coming telling me, sir, initially she was not able to touch the ground, but now she's able to do it. They feel it's a lot of relief. But I would say from now on, always try to look, range of motion. Try to understand the muscle that is involved. Always try to, dissect it, understanding which muscle is involved. So it will be a lot easier in understanding its pathology, right? Next, we are going to talk about the medial rotation. So, okay, so this is medial rotation is when you keep the thumb like this and then rotate it towards the midline, right? This is medial. Or when you talk about, or when you, in this position, this is, right? This is medial rotation, or this is internal rotation, right? Medial rotation, internal rotation. Also this, right? This is also internal rotation. Now, what are the muscles that is involved in the medial rotation? It's produced by the contraction of the subscapularis, right? So you have the scapula here, right? If you can see it. That's my gravity. Okay. So the subscapular is here on the anterior aspect, right? It is connected to the humerus, and what happens is it needs to rotate. That's the medial. You have the pectoralis major in front, latissimus dorsi, teres major, and anterior deltoid. Isn't this one of the most common conditions that we see in clinics today? People coming, they tell you, right, sir, we are able to flex, we are able to extend, but then I'm not able to touch my back, or I'm not able to scratch my back, or women come and tell you they're not able to wear their clothes, taking them at the back. That's the most common because they get severe pain here. So then we analyze, okay, so the muscles are subscapularis, pectoralis major, latissimus dorsi, teres major, anterior, that is affected, right? And the antagonist muscle for that would be this is the lateral rotation, right? Like this, produced by the contraction of the infraspinatus and the teres minor. Very important. And this teres minor is, it always plays, havoc, and people come to you with a lot of problems, especially in the upper back. Okay, so I hope this is clear. This is how we analyze each joint. This is how we understand the movements in each joint. Because only when we understand the muscles that are involved in motion, that is in responsible for the movement of that particular point, only then can we understand how to stretch it, how to do isometric stretches and all the stretches that we learn. So I'll do just with the slide because the slide was off last time. So the extension produced by the posterior deltoid, latissimus, okay. The posterior deltoid, latissimus dorsi, and the teres major that is involved in the extension. Flexion is produced by the biceps, my pectoralis major, anterior deltoid, and coracobrachialis. And then the abduction, we talked about 0 to 15 degrees is your supraspinatus, then is the 15 to 90 is your deltoid, and 90 degrees is where the scapula gets rotated, right? This is done by trapezius and serratus anterior. Adduction produced by the contraction of pectoralis major, latissimus dorsi, and teres major, and we talked about medial rotation, internal rotation, contraction of subscapularis, pectoralis major, latissimus dorsi, teres major, and anterior deltoid. Lateral rotation away from the midline, right, produced by the infraspinatus and teres minor. So, somebody comes with neck pain. What do? Step 1, we understand the anatomy and the direction of the muscle fibers, right? So for the neck pain, what is involved? You have the splenius capitis, very important muscle for the extension, You have the trapezius, again very important for the extension. You have the rhomboides minor, rhomboides major, because it is connected to your, the upper part of the thorax. Then you have the occipitalis, and you have the scalenes posterior. You have the scalenes medial, anterior, and also the sternocleidomastoid. So these are the muscles that you have to look for, especially when we check for neck pain. And what we do, we ask the person to sit, and this is the direction when we go for.
So you people have to
देख मेरा करना है
पानी जाने वाला है ना
क्या हुआ
अरे पानी आने वाला केने जल्दी फोन
ये वाला फ़ोन देना है दे
मम्मी वाला फोन देना
मेरे पास नहीं है
कवर तूने वहाँ रखा है
मेरे तो लिया भी नहीं मम्मी का फ़ोन
नीचे दिन को ऊपर जाएगा मेरे